right. So my name is Courtney Wusthoff. I am a pediatric epileptologist up at Stanford. And my particular area of interest is neonates, newborns who have seizures, as well as babies, infants who have seizures. So what we have some time to talk about over the next hour or so are seizures in babies and why they occur. But my hope was to keep this a little bit informal and interactive so that we can talk about the things that are going to be most useful to you guys. So for the first couple of minutes while people are getting on, my hope is that we can use the Zoom features today. Some of you I know are using Zoom probably far more than you want to. And for some people, Zoom is a relatively new thing. So the way that we can use it today would be both with the chat feature as well as the annotations feature. So if you are able to get next to your device, next to your keypad, that would be helpful because we can take a look and see what we can do as a group together today. So if you've not used chat before, this is how you can turn it on your screen. This is using a desktop, but it looks pretty similar if you're using a tablet device or a phone. You go down to the bottom of the screen, you look for that little chat bubble, and it'll click open the chat window on the right-hand side. And then anything you type down in the messages is going to be visible to anybody else in the group. So just as a sort of starter, a practice, what questions or topics do you guys want to discuss today? So I would say give it a try, that chat bar. I know there were some chats from the last talk. If anybody has any particular questions on their mind or reasons that you joined this session, enter it into the chat, and that way we can be sure that we talk about it. And again, just as a reminder, the way that you can access that chat is by going to the bottom of your screen. You should have a chat bubble that shows up, and then you can type in questions on the side. All right. So it looks like we've got a question. Do infants grow out of epilepsy? Ooh, that's a good question. We'll talk about that for sure. And then maybe an easier question, because sometimes people join in talks and they're not quite sure what they want to learn, sort of want to see what comes up, but something that all of us can answer. Where are you joining in from today? We usually get a nice mix of people. So if you feel comfortable with it, enter into the chat where you're logging on from, whether that's within California or outside of California. The shy group. All right, well, one other thing that we can try, which sometimes is a little bit easier, how can I best support my son's epilepsy? Should I take notes? Redondo Beach, excellent. I'm originally from San Diego. I miss Southern California. I'm just going to write some of these down to make sure that we cover them. And another thing that we can do to help interact with each other that's sometimes a little bit more comfortable because you don't have to put your name next to what you're talking about is the annotations feature in Zoom. And I love this because it lets you put up a thought, but you kind of get to be a little bit anonymous. So if you haven't used this before, if you go up to the pencil looking thing on your Zoom window, you can select any of these features, text, stamp, and you can actually draw on my screen, which is kind of fun. So let's give that a practice, and anybody should be able to answer this one because whether you're just sitting in or if you have a child who you're interested in asking questions about today, we can all answer this question. Are you here today as a parent, as a healthcare provider, or some other role? Feel free to put in your stamp or your mark under one of those categories, and it would help give me a sense of who's in the group today. All right, so one healthcare provider. Anybody else want to give it a try? An other, okay. Parents. Okay. All right. So we can try using both of those throughout the next hour or so to interact, but we can also just ask questions while we're talking with each other. So what I hope to do for the next about 45 minutes is to talk about some of the most common types of seizures in babies. And I'll start out by talking about seizures in newborns, because I think that that's a little bit of a different group than seizures in infants. And we'll feel free to ask questions as we go, because there might be something that I could spend a little bit more time on that might be especially useful for you. So in general, when we're talking about seizures in newborns, I'm talking about babies who are quite little, the ones who are just about a month or less. And so these are babies who start to have seizures, often even before they go home from the hospital after birth. But sometimes they might make it home for a week or even 2 weeks and then end up coming back to the hospital when the seizures start. And seizures in newborns fall into two big groups. One are seizures due to an illness or an injury that's happening right around that same time. And the other group are babies who truly have neonatal onset epilepsy. And what that means is that they have a condition that's expected to be lifelong, that's going to cause epilepsy, or is expected to last for at least several years and cause epilepsy. And it just happens that their first seizures came out when they were newborns. Now, some babies make it a little bit further. They go through the first few weeks without having any seizures, but they might have seizures diagnosed in the weeks or months after that. And that's often described as an infantile onset epilepsy, with infantile spasms as a particular type. So one of the things that's tough about neonatal seizures or seizures in newborns is that they're really hard to diagnose. They happen rarely, which is a good thing, but enough that we have clinics just for babies who have early onset epilepsy. They happen in anywhere from 1 to 5 per 1,000 term-born babies. They're a little bit more common in babies who are born early, babies who are born premature. And part of what's tough about the diagnosis is that neonatal seizures might have no outward clinical signs, and lots of things that are called seizures in newborns aren't really seizures. And so I'll tell you a little bit more about what I mean. So for most older children or adults, when they have seizures, there's something that happens that brings your attention to it to say, oh, that may have been a seizure. And so, for example, the most obvious kind is the generalized tonic-clonic convulsion, where someone suddenly stops and stiffens and starts shaking all over. But newborns don't really have that kind of seizure. To have a generalized convulsion, the connections in the brain have to be well developed enough that a seizure can be triggered in any part of the brain and essentially spread to the entire brain simultaneously. And that's what it is to have a generalized seizure. Newborns, their brains are still developing. The connections between different parts of their brain are still developing. And so it's really rare, almost, never say never, but almost unheard of to have a truly generalized seizure in a newborn. Instead, what newborns have are focal seizures or partial seizures. And what that means is the seizure starts in one part of the brain, and it usually stays there, and it doesn't spread to the rest of the brain. And just like with older kids, what part of the brain is involved in the seizure is going to determine what the signs of that seizure might be. And so if that seizure happens to occur in the part of the brain that causes motor movements like shaking or stiffening, then you might be able to see it. But if you think about a seizure that an older kid has that might be just staring off and then coming back, well, that's obvious if it's an adult or if it's an older kid. But for a newborn, if a newborn just stares off and comes back, well, that can be really hard to know if it's a seizure or not. And so newborns who have seizures, often their seizures are missed, particularly in the beginning, where maybe mom knows something's not quite right, or maybe there's other things that are going on, and it's not until they get an EEG that you realize that these episodes are seizures. And sometimes it's just impossible to tell. When you think about older kids or adults who have epilepsy, sometimes their seizure is just a funny smell, or it might be flashing lights, some sort of visual phenomenon. And a newborn doesn't have a way of communicating with us if they have that sort of an experience as their seizure. So unfortunately, newborn seizures are really difficult to diagnose by looking at the baby, and it is pretty common that they might not be instantly recognized, and you do need to have an EEG test to know for sure. Making it extra difficult is that once you know a baby has seizures, well, then everything starts to look like a seizure because you're worried. You don't want to miss any seizures. And so we all start watching the babies really closely. And then you say, well, was that lip smacking a seizure? I think he just stared off there. Was that a seizure? He just kind of did a funny burp. It wasn't a regular burp. Is that a seizure? And I really feel for parents because you can sort of worry that anything a baby does is a seizure if you're looking hard enough. But obviously you don't want to keep increasing medication for every single thing that might be a seizure. You really want to know for sure. And so again, having EEG can be really useful for figuring out what is a seizure and what's not a seizure, even if you already know that the baby has seizures or has epilepsy. So here's an example of my favorite not seizure. And the family was very kind in giving me permission to share this video with you today. So you can see that this baby's asleep and has some arm jerking. It's real quick there and then it stops. And it sort of comes and goes. So this is my favorite because this is something that's harmless. This is something that we see in babies anywhere up until about 6 months of age, and it's called benign neonatal myoclonus. And one way to think of it is when you're falling asleep, sometimes you have that leg kick, you kick your partner or you kick the bed. Babies do that too, but they do it a lot more than we do. And so they'll have it like this off and on, sometimes for minutes at a time. Sometimes it'll be in one arm and then it'll spread to the other one and then it'll spread to a leg. And particularly if you know that your baby is at risk for seizures, or if they ever had seizures in the past, it might be understandable to see something like this and worry it's a seizure. But this is just one example of something that can be a seizure mimic or a fake out for seizures. So what about babies who do have seizures, where the newborn has the EEG, it confirms that there are seizures? Well, what causes seizures in newborn brain? Most of the time, about 80% of the time, when newborns have seizures, it's because there's something that's happening in the brain at the same time, some sort of illness or injury. And in the United States, the most common cause is hypoxia ischemia. Sometimes it's called HIE. Sometimes it's called neonatal encephalopathy. And this is a condition of the brain not getting enough oxygen or blood flow around the time of delivery. And that can cause newborns to have seizures. When that's the cause of seizures, they usually start within the first day or two after birth. And usually the baby is also sick. So it's not something you would see in an otherwise healthy newborn who has seizures. But in a newborn baby where you already know that they're sick, that can be a reason for seizures. And that's the most common cause of seizures. For newborns who seem to be doing fine after delivery and then start having their seizures, the most common cause is stroke. And it's often a bit surprising to hear that newborns have strokes, but actually newborns, that first week after birth is the highest risk time period for stroke at any time in your life, if you had to pick 1 week. And that's because babies, their blood clots more easily than it does at any other time in their life. So another common reason for newborn babies to start having seizures is stroke. And then there's other things that are less common, like infections or having changes in your electrolyte levels or your blood sugar levels. But what about those babies where it's not that they have something happening right now, they're not ill, they didn't have any brain injury, but this is actually the first seizure that's the start of neonatal onset epilepsy. So there are a couple of things that we look for that are most common for those babies. Far and away, the most common thing are genetic causes. And there's a particular type of potassium channel where if there's changes in the gene for that potassium channel, that can cause seizures that appear in newborn. And the name of that is a KCNQ2 gene. And so if you have changes in that gene, that's a common cause of seizures in newborns. You can also have differences in the way that the brain is formed. And that's something that you're going to see on an MRI scan. So if you only have a couple of tests to look for why a baby has seizures or why someone has seizures if they started as a newborn, your MRI is the thing that's most likely to give you a diagnosis because you'll be able to find the answer in almost 90% of babies. And it works because it shows you both if there had been some earlier injury that caused the seizures or if there's some sort of structural difference in the brain that causes the seizure. MRI is incredibly useful for figuring out why a newborn has seizures. If the MRI is normal, then it's time to move on to genetic testing. And I'll say that this is something that's really different now than even when I trained. I'm not that old, but when I trained, if a baby had a normal brain MRI, then they were just said to have fifth day fits, is what they used to call it. And they would say, well, some babies have seizures, and we never figure out why. And now we can figure out why. So another sort of take-home message is that you shouldn't rest at, well, just because, until you've at least done due diligence to look for the cause with some of the modern options that we have available. So for babies who have seizures and their MRI doesn't give an explanation, genetic testing is going to give you an answer more than half the time. And the genetic tests get better and better every year. So that's the testing that we would do to find things like that potassium channel change. But there's also dozens of genes that have been identified that can cause seizures for newborns. And so for both MRI and genetic testing, because the technology is getting better and better every year, what we'll do now is we'll do the MRI, we do the genetic testing. Sometimes we don't find an answer, but then we keep having those babies follow up in our epilepsy clinic, because a genetic test may not be able to give us an answer this year, but it may be that a year from now, the technology has improved enough that we can get a diagnosis. And I've certainly seen that in my own patients, where when they were first born, we weren't able to identify a cause, but now maybe they're 3-4 years old, we have better options for diagnosis, and we're able to get some of those answers. So when we talk about causes of infantile seizures or epilepsy in babies, there's 3 big kinds of groups that people will sometimes use to describe it. I'm not sure how useful these are because they're pretty overlapping. So for example, people will talk about genetic causes of seizures, and that's again like that potassium channel mutation. People will talk about structural or metabolic causes, meaning that there's a difference in the way the brain is shaped, or there's a difference in the way the body processes or uses energy. And then there's this whole big group of unknown, and that's really unsatisfying. The last time that this descriptive system was endorsed or revised was 2010. And so it's due for another revision, and we're told that another one's going to come out in the next year. Hopefully it's going to improve upon this, because I think we have much better options. One question that came out in the chat that I think is relevant to this is, can prenatal exposure to alcohol and illicit drugs such as cocaine and heroin cause epilepsy? It can, and I think that's an example of one of those groups that probably in the past would have been just described as unknown. It can lead to epilepsy or seizures in a couple of different ways. So for neonates who have been exposed to different kinds of substances during a pregnancy, it can trigger seizures as a newborn through a few different ways. One is through withdrawal. And so we know that neonates who are exposed to opioids, that's like heroin, morphine, those sorts of things, when they're born and they suddenly have that taken away from their system, they have withdrawal symptoms. And in the most severe cases, that can trigger seizures. So that's one way that illicit substances can trigger seizures for a newborn. If there's any good news about that, it's that once the baby gets through that withdrawal, usually the seizures are done. And so that's a cause for seizures that happen in the days and weeks after birth, but it usually doesn't cause a lifelong epilepsy. Other kinds of substances can cause injury to the brain itself. And so cocaine is a good example of that, because cocaine changes the way that blood vessels work. They constrict after somebody uses cocaine, and that can change blood flow to the baby in utero. And that can trigger things like differences in brain development. It can even cause stroke. And so in those cases, if there's been significant exposure where it impacted the blood flow getting to the developing brain, then you might be in a situation where, yeah, because of that difference in brain, that's a baby who might develop epilepsy later on. And that can be difficult to prove, that relationship, to say it's definitely the cocaine exposure. But it's something that certainly, if you've looked for all of the other causes and you know that there was that sort of exposure, it's a known risk factor. In utero alcohol exposure or fetal alcohol syndrome, it's been described to cause epilepsy. It slightly increases the risk of epilepsy, but not significantly, not in the same way that we know that having opioid withdrawal can cause seizures, or we know that having differences in brain development can cause seizures. So it's a risk factor, sure, but it's not a major cause of seizures in neonates. That's a great question. And for some kids, it's not clear what's a genetic condition and what's a structural condition. And so one example is tuberous sclerosis complex. Kids who have tuberous sclerosis, they have a genetic cause for their condition, but it also causes changes in the way that their brain is formed. And so do you count that as a genetic cause or a structural cause? In a sense, it's a little bit academic. What matters is that you know what's going on, because it helps you understand how to treat the epilepsy and what to expect next. All right, so I saved this because the question came up earlier, but I think that it's relevant at this point. So sometimes babies have these seizures because of something that's happening right now, like withdrawal, like HIE, or like a stroke. And the question is, well, do they have to take medicine forever? What's the chance that they're going to outgrow it? And if they just have seizures as a newborn, particularly because of an illness or an injury that's recent, then most likely they're not going to need to take medicine long run. So of all the babies who have seizures, only about 20% of them go on to develop epilepsy. It's still much higher than the general population, but it's only 20%. And so one way of thinking of that is that 80% of the babies who have seizures don't go on to develop epilepsy. There are some clues that we can use to try to understand what a baby's risk is of having epilepsy. So the size of injury on the MRI scan, if it's something like a stroke or hypoxic ischemic encephalopathy, how bad the seizures were. Babies who need multiple medications to stop the seizures while they're newborns, they're much more likely to have ongoing epilepsy and need to keep taking medication. But one thing that we've learned pretty recently, and again, this is a shift in practice just over the last couple of years, is that not every newborn who has seizures needs to continue taking medicine long term. And I'll say newborn, when I talk about newborn, I mean a baby who has seizures in the first 30 days. Infant is anybody up until about 2 years. So newborns are really the little babies. And it used to be that any newborn who had seizures, if you had seizures in the first 30 days, you would usually get started on a medication, and sometimes some pretty nasty medications. And babies would stay on medication for years because everyone was afraid that stopping that medication was going to lead to their epilepsy coming out and make seizures come out, and that they'd be hard to get under control. But it turns out that for the babies who are having seizure because of an acute illness or an injury, stroke, like HIE, most of those babies can stop medication even before they go home from the hospital, meaning that you can treat the seizures as they happen, but by the time the baby's recovered from whatever was causing the seizures, you should be able to stop the seizure medicine. And that was shown in a study that was just presented at one of the meetings this year, where we followed 300 newborns who had seizures, and we compared those who had seizure medicine stopped before they went home to those who had seizure medicine continued after they went home. And what we found is that the babies who had seizure medicine continued after they went home, they were likely to continue it for several months. But those babies didn't have any protection against developing more seizures or against developing epilepsy. It was the same rate of epilepsy in both groups. And we did find that the babies who were kept on medicine for longer had lower developmental scores when we followed them up at 2 years. And so we did this testing called a WDEA test, and it just helps to assess a child's development at 24 months. And we found that the babies who stayed on medicine for longer were more likely to have developmental impairment, 38% of them, as compared to the babies who stopped medicine early. It was only 29%. So it's really important to understand what the cause of the seizures is, because that can guide you for how long you need to continue the treatment. And certainly if it's safe to stop the treatment, you want to stop it because nobody needs extra medicine. And there is that worry that maybe continuing unnecessary medicine for longer than you need it can result in developmental impairment in the long run. So that's one answer, and we can talk a little bit more about the specifics of can babies outgrow epilepsy. Certainly newborns who have seizures can outgrow their seizures. Now, in contrast, depending on the cause, you might be very unlikely to outgrow epilepsy. And so For example, an epilepsy that's due to a difference in the way the brain developed, a difference in cortical folding or brain malformation, that cause is always going to be there. And so that baby is at risk for epilepsy that's going to be lifelong. And so just to sort of show you some common causes of seizures and how long those seizures usually last for. So benign infantile neonatal, idiopathic neonatal seizures. These are kids who have seizures that start around the 5th day. And it's pretty similar to this group of benign familial neonatal seizures. The babies look great, they're doing well, they usually go home with mom, and then somewhere between the 2nd and 5th day, seizures start. And then the seizures go away. They outgrow the seizures anywhere from the first few days, if you're lucky, more often up until about 6 to 12 months. But about 75 to 80% of kids who have this kind of neonatal epilepsy will outgrow it by a year. And the reason for that is that it affects just one particular part of the cell that's only present in newborn brain. And as the brain matures, that protein is no longer used, and so it doesn't matter anymore in terms of causing seizures. In contrast, there's other kinds of epilepsy syndromes, like benign familial infantile seizures that will start a little bit later, that you can still grow out of, that we do have genetic testing identified for. And so you get some clues from when the seizures start, what kind of seizures they are. If you find that cause, the genetic cause, or if your MRI shows you a cause, that gives you really good information about what to expect. And sometimes we can give great news, like, yes, you are very likely to outgrow this epilepsy in the first couple of years. And sometimes it's less good news, but at least we have some more information about what to expect. So I might pause for a little bit here, because I'm not sure if I totally answered that question about, can infants outgrow epilepsy? So I don't know if anybody wants to unmute themselves and ask a little bit more about that, or enter a question into the chat.
Hi, I was the one that asked the question, and yes, you did. I think for us, we still don't know the cause. So, I mean, I guess we're just kind of still in this journey.
Can I ask how old your child?
Yes, he will be 5 months this week. Okay. So yeah, he was diagnosed at 3 months. I thought something was going on before he even turned a month. And I actually brought it up to the doctor, because we were seeing the pediatrician there then every week, because he wasn't gaining weight. And he was like, no, it's not a seizure. It's more likely a reflex. Try recording it, but it's just likely that it's a reflex. So it was so hard to record, because it would happen so fast, because his seizures last about 20 seconds or so. And by the time you kind of grab your phone, it would be over. So I finally was able to record it like right before he turned 3 months, and I sent it over to him, and he said, he thought it was something, it was just abnormal. And that's when they brought us in to the hospital.
Yeah, unfortunately, that's a really common experience, that babies who start to have seizures early on, because most of the time if a baby does something funny, it's not a seizure, that they can have this long diagnostic odyssey before you really understand what's going on. I'll say that, I'm going to jump ahead a little bit. So for kids who have their epilepsy start as infants, meaning before they're 3 years old. So not in the first couple of days after they're born, but pretty early on, anytime in the first 3 years. That's often described as an early onset epilepsy, or an early life epilepsy. And we don't get the answer for quite as many babies in that group, but we're getting better. And so some of the more recent studies show that when you do genetic testing, you can find a cause in anywhere from 20 to 40% of kids. And this is absolutely an area where I see us getting better technology, really month by month, where some of the things we did even a year ago, we're able to do better in terms of looking for a cause. It's less common in kids who start with their epilepsy or start with their seizures in that infant age group to have a brain injury, because usually they're sick when they're first born. But it can happen. It can happen that when you do the MRI scan, you discover that there's something there that you didn't realize was there. But unfortunately, about half of kids even after they get the diagnosis of epilepsy, they end up waiting for more than a month to confirm that it really is epilepsy, that it really is a seizure, and in some cases much longer than a month. I would say that the advice that I have for patients who are in that group is that I think it's pretty standard to get the MRI scan. And certainly the MRI is important, but there's still some people who don't do genetic testing universally. They'll only do it if there's a parent who has epilepsy or a brother or sister who has epilepsy. And I think we're really past that. I think that the tests we have to offer are good enough that any baby who has their epilepsy start before they're 3, it's justified to do the genetic testing. I've had pretty good luck getting it covered by insurance. I can't say I'm 100%. But I'm better than 90% probably in getting that genetic testing covered, because there are some specific causes of epilepsy that really do change how you treat them based on the genetic cause. So one that I showed in that earlier slide is something called SEN2A, which is a gene change that has to do with sodium channels in your neurons. And depending on what kind of gene change you have, it can tell us that a whole class of seizure medicines is either really, really good for your epilepsy or really, really bad for your epilepsy. And so it's incredibly useful information to have, because once you get that result back, it changes the treatment in a way that keeps kids out of the ER, it keeps them from having status epilepticus. And that's the kind of argument that I've had the best luck with insurance companies and getting genetic testing covered. The other thing that I recommend for families is when we do the MRI and we do the genetic test that we have available now, and we don't find a cause, is to consider repeating it. And there's a couple of time points when it might be useful to repeat it. So anybody who's had genetic testing where it didn't give them an answer, having a follow-up about every year or 2 with a geneticist is a reasonable thing to do. And some families have had enough, and that's okay. But because the technology is evolving so quickly, what's not available now might be available a year from now. And so it makes sense to have those check-ins to see what new things have been learned and what new options there are. The other thing to consider is the MRI scan. Babies' brains are developing so rapidly that sometimes you can see things on a later MRI scan that you can't see easily on an early MRI scan. So in particular, the white matter of the brain is developing very, very quickly, and it's hard to assess in a baby who's less than 3 months old. And if you do an MRI scan before 3 months, any differences in that white matter part of the brain might be invisible. If you repeat the MRI after the child's 2 years old, then the white matter is almost entirely developed, and that's a much more likely age to be able to see some of the very small, subtle differences for something that might be causing seizures. So those are 2 of the kinds of tests that I think about repeating. I don't want to repeat things unnecessarily, but those are 2 things in particular that I think should always sort of stay in the back of the mind for trying to understand what the cause is. Rarely, we just don't have the answer. And so then we proceed with trying to treat as best we can. But I've had some patients where even when we weren't able to identify a cause through MRI scans or genetic testing, when we did the EEG, we saw the seizure was always coming from the same place every single time. And so those were patients where epilepsy surgery was helpful. And sometimes it's not until you do the surgery and you take out that tissue, that part of the brain that's causing the seizures, and then under the microscope, you can see that there's a difference on a cellular level, and then that's why the seizures were happening. And unfortunately, we're just not able with what we have now to be able to tell that from an MRI scan or a blood test. I think maybe I'll talk just a little bit about infantile spasms, because I think that's something that comes up a lot when you're talking about seizures in babies. And it's an important topic. So there's seizures that happen in infants. There's epilepsy that happens in infants. And then there's the syndrome of infantile spasms. And that's a particular kind of epilepsy that usually starts anywhere between age 6 and 24 months. And it has this characteristic EEG pattern that goes along with it called hypsarrhythmia. And I'll show an example of that. It's really important to diagnose early because we know that rapid treatment can improve outcomes, and that delays in treatment increase the risk of having problems later on after infantile spasms. But sometimes that hips arrhythmia pattern, which is key to making the diagnosis, it might only appear during sleep. And so if you think a baby has infantile spasms, you really have to get an EEG where they're all the way asleep, not just drowsy, not just drifting off, but really all the way asleep to know whether or not it's there. And sometimes we even admit kids to the hospital overnight for those EEGs to make sure that we've looked all throughout sleep for that pattern. Infantile spasms can be caused by lots of different things and end up in the same place as having infantile spasms. So for example, some babies who start with seizures when they're young babies in the first weeks or months might just have occasional seizures, and then once they get into that window of infantile spasms, their seizure type changes into more of a spasm. For some babies, we know that they're at risk for infantile spasms, and again, I'll use the example of tuberous sclerosis. Those are babies who have a difference in the way their brain is structured. They often will have seizures as newborns, but then once they get to that age window of 6 to 24 months, they have infantile spasms. And for some kids, we don't find the cause. This is the EEG pattern that we're looking at for infantile spasms. And if you've ever seen an EEG, usually you have that nice squiggly line pattern that shows the brain waves. And in infantile spasms, it's a very high amplitude brainwave pattern. It's chaotic. It lacks normal organization. And this is what the spasms look like. You can see this little guy is just sort of laying on the bed, getting his EEG, and then the hands fly up. I'll show it again. Doing his baby thing, and then the abrupt sort of extension of the arms that go up. Now, that's a pretty dramatic spasm, and not every kid has a spasm that's that obvious. Sometimes it can be a little bit more subtle, especially in the beginning. Sometimes it can be just a shoulder shrug where the arms don't go all the way up, but it can be that sort of arm lifting with a shoulder shrug. Once infantile spasms start, they tend to come on like gangbusters. So you'll start seeing them one day, and by the next day, babies are having 6, 12, 20 spasms in a day. They tend to come in clusters right around the time the babies wake up. So that's what they look like. And I bring it up in talks like this because if a baby has had seizures before, either as a newborn or early in life, it's something to be aware of, because if you see a change to that seizure type with those sort of spasms, either the arms going up or stiffening, you want to get checked out right away, because the treatment for infantile spasms is different than the treatment for other kinds of epilepsy. There's only 3 treatments that have been proven to work well for infantile spasms. They're not perfect, but they work better than other kinds. And that's one is an injectable sort of steroid called ACTH. One treatment is oral steroids like prednisone or prednisolone, something that the baby takes as a liquid. And the last one is vigabatrin, which is a prescription medication. And those are not medicines that you would otherwise be using for most babies who have seizures or epilepsy. So you really have to recognize the spasms and make that diagnosis to know that it's time to switch over to one of these more common treatments. So those were the things that I had thought about talking about today. I think in terms of why do babies have seizures, the most important thing to know is that for most babies, not all babies, but for most babies, we are able to find an answer. And I suspect that the babies we don't have answers for today, we might be able to get better answers for in the future, because this is an area of such intense research and such intense development. Certainly the MRI and the genetic testing are the best places to start. And you might end up having to repeat those if you don't get an answer right away. And then as we get better and better with the science, hopefully we'll be able to understand more and more about some of those babies where we don't know now, but in the next couple of years we will. I'll stop my slides there. What other questions can I answer?
Hi, Jen again here. One of the items that or one of the questions I had from earlier was, so I have an app called Epilepsy that I've been using to track his seizures, but I don't know if I should be doing more and like how I should be tracking or journaling, because especially as we're trying to explore the different medications, you know, I've noticed like his seizures have changed too. And I don't necessarily have like, okay, on this date, it was look more like this, as opposed to in this date, it was more like this. So just, I mean, I think I'm just overwhelmed, you know, when you first find out, you're trying to like figure everything out and understand everything. So just what advice you have and what tips you have as far as like how I should move forward with this?
Yeah, I do think it's helpful to track seizures when you're making changes, or if you think that something has changed about the seizures. What works best is really different for different families. There are some families where the devices seem to be more hassle than they're worth, and in that case, just an old pen and notepad can be easier than trying to fidget with an app, especially if multiple people are with baby at different times a day. Trying to like sync up the app between different people can be more trouble than it's worth. So it's okay if what works for you is just having a notebook and a pen that stays with baby, and when people see seizures, they can note it. But for other people, the apps are much easier to use, especially if you're someone who sort of has your phone with you all the time. And then there's not necessarily one app that's better than the others. The things to look for: you want something that's going to make it easy to enter in. You don't want to do a whole lot of typing every single time there's a seizure. So most of them you can set up a button or a seizure sort of click. That was the seizure. And most families will come up with sort of nicknames for their seizure types, because you just describe what you see, right? And so I'll have families who'll say like, oh, she did the scrunchy face seizure again. And that's how we talk about it. You'll say, well, she had 6 scrunchy face seizures on Monday, but then she didn't have any on Tuesday. Wednesday, she made a face. I'm not sure if it was a scrunchy face seizure. And then Friday, there were 3. And for other families, it'll be, you know, a leg twitch seizure or a lip smacking seizure. And once you figure out sort of what it looks like to you, it's okay to use that nickname for it, and use that nickname in your journal and use it in the app. I don't care for the apps or the systems that force you to choose one of their descriptions, because that may not be what it looks like for your baby. And it is helpful to know how often are the seizures happening, how often are they lasting for, and what they look like, because those are the kinds of things that are going to help you know if you're headed in the right direction with the meds. How often the seizures are happening, because sometimes you need to have that tracking to be able to know whether or not you're making any progress. An example will be if your baby's having 10 seizures a day and then you change the medicine and they're having 5 seizures a day. Well, 5 seizures a day is still too many, and you still have more work to do, but at least you know you're headed in the right direction. But if you haven't been tracking in that way, sometimes it can just feel like, well, he's still having a lot. It's still a lot of seizures. So how many is useful for that reason. How long they're lasting for can be really helpful. Sometimes with medication, the seizures will be shorter, or sometimes families will say they're just less severe. And that can be incredibly useful, because then even if it's still, you know, 3 seizures a week, but it's gone from being 3 seizures a week that last 2 minutes to just 3 seizures a week that last for 15 seconds. That's really good progress. And the same thing in the opposite direction. If there were seizures that were happening that were getting longer or more pronounced, then that would be something that would warrant making some changes. And then, like you said, what the seizures look like can be really helpful. In infants and babies, because their brain is constantly changing and growing and developing, it's really common for the seizures to change how they look over time. And what a seizure looks like in a 1-month-old is probably going to be different than what their seizures look like when they're 6 months old or when they're a year old. And sometimes you still use the same medicine to treat them, but sometimes, for example, like the infantile spasms, it's a clue that you really need to change the way that you're coming at things. So those are the 3 kinds of things that I'm usually looking for in any kind of seizure tracker. Is it going to let me count how many seizures there are, how long the seizures lasted, and what they looked like? And I don't think you have to make yourself crazy with did the seizure last for 17 seconds or 20 seconds, you know? Just getting an overall sense of, is it seconds or minutes or longer than 2 minutes, or did you have to give a rescue medicine? That's important.
Okay, thank you. And if there's something that you think looks like a seizure, but you're not sure, do you still mark it as a seizure?
So I usually tell families to have a different kind of code for that thing, because it's really common that there are things they know for sure are seizures, and then there's things that they're not quite sure if it was a seizure or not. And so sometimes it'll be like a seizure question mark, or if there's one type of movement that the baby's doing over and over again and we haven't figured it out, then we'll come up with a different code word or a nickname for that kind of thing. And sometimes that's another reason to bring a baby into the hospital for an overnight video EEG, is maybe we know that the things that are definitely seizures are under control, but if they're still having other kinds of spells or episodes where we're not exactly sure what it is, it's worth figuring it out with the EEG before you add another medication. You want to make sure you're not chasing something that's not a seizure.
Thank you.
You're welcome. Another question in the chat is, what if for a baby you know that biomom has epilepsy, but you don't know any more than that? Are there tests that I would recommend, and what would be an appropriate age to do the test? That's a great question. I'm pausing because it's a good question with a little more complicated answer. So for adults who have epilepsy, there's tons of different things that can cause epilepsy. And not everything that you get told is epilepsy is necessarily epilepsy. Sometimes it's a seizure that's provoked, that was caused by something like a car accident or trauma or substance use. But sometimes it really is epilepsy. I think that in those cases, I still go through the same order of steps, but you definitely want to do all of the steps. So I still get the MRI scan, because some of the things that change the brain structure that you see on an MRI scan can run in families. And so it may be that biomom had a difference in the way the brain's formed, but she never knew it. It's actually pretty common, because if you think, 20 years ago, people weren't getting MRIs of the brain very often. So it's still worth doing that for the baby. And then most of the genetic tests that are available for early life or early onset epilepsy, you can do without having the biological parents' DNA samples for comparison. And those are tests where you just need the baby's DNA, and that can be blood or saliva. And it looks for the most common known genetic causes of epilepsy. And if you find one of those things that we know causes epilepsy, then you have an answer. The place where it can get trickier is with some of the newer technology. Sometimes the testing lab wants to have a sample from biomom, or even biomom and biodad, which is even harder to get, so that they can compare the baby's DNA to the parent's DNA to look for changes. And in those cases, it might not be as practical to go down that line of testing, but you can certainly do that first level of genetic testing. Sometimes they're called gene panels, that looks for the most common genetic causes. I think that the appropriate age to do the test, if a baby has their epilepsy start before they're 3, I think it's a useful test to do, because it often gives information that changes how we treat the epilepsy. And that's, again, because certain genetic causes, you have to use certain medicines, you have to avoid medicines, or it tells you what to expect for how long the baby's going to have epilepsy. For older kids, if the epilepsy starts later in life, then there's also the question of how much does the child want to know about the cause of their epilepsy? Every family and every individual thinks about knowing your own genetic information in a different way. In some families, people really are interested and curious about it and want to know about every different gene that they might carry. And in some families, that's not information that people want. And knowing that as an individual, I have a gene change that I might pass on to my own children might be seen as something I don't want to know about. So for older kids, and particularly teenagers, then I think it's important to talk with them about whether or not it's, they're at an age and of a cognitive level where they can have that conversation to talk about whether or not they would want to go ahead with genetic testing. It's also the case for epilepsy that starts later in life. It's less likely to be one of those kinds of genes where the information is going to change your treatment immediately. That's a long answer, but it's a good question. Any other questions? I'll hang around for another couple of minutes. I think we're wrapping up. Give you guys a couple of minutes. You've probably been on Zoom all day. You can get some coffee or some water or stretch before you go on to the next session. I'll be around if anyone thinks of any other questions. And thanks for having me here today. It's always a pleasure to join you, and hopefully next year we'll see each other at Disneyland.
Dr. Wusthoff, thank you so much for your time and your insight. Thank you.
My pleasure.
I have a question if no one else does. So I think I just said, so my son's, his seizures last about 15 to 20 seconds. I think the longest one he's ever had is 30 seconds. The most he's ever had in a day are 7 seizures. But as far as like, in your experience, what have you seen with like brain development with, you know, having seizures? Like at this point, we think he's developing well, but you know, we're not sure, and we're not really sure when we would see that. So just kind of what's your experience with that?
That's a great question. Thanks for bringing that up. We're always trying to find that balance between having as few seizures as possible, but also considering the potential side effects of giving a whole lot of medicine. And it really does get at that in the long run. How are these things impacting brain development? The best science we have says that babies who have very long seizures, meaning seizures that last for longer than 30 minutes at a time, they're at risk for having brain injury just due to the seizures themselves. So the babies who have status epilepticus, where the seizures last a long time, then I do worry about that causing, the seizure causing changes to the brain. Over time, if you have lots of little brief seizures, those 15, 20-second seizures, but let's say, I hope it doesn't happen, but if they're happening 7 times a day, every single day, that can interfere with development, not necessarily through changing the brain structure. We don't really know whether or not that changes brain structure, but it does interfere with the baby's ability to interact with the environment. Anytime that your brain is having a seizure, it's not doing the stuff that it should be doing. And for babies, that's just learning about the world around you and developing. So certainly fewer seizures is better in terms of development, but single isolated brief seizures, meaning less than a minute, especially if they're not happening on a daily basis, those are unlikely to cause changes to brain structure in the long run. Of course, we always want to get to know seizures, but then you have to balance it against the impact of the medications, and every child's different. There's some medicines that we know are sedating. So phenobarbital, even though it's the drug that's been around forever for treating babies who have seizures, it can make them really sleepy, and it can interfere with learning, absolutely. So if there's any other option that we can use, I usually jump to that pretty quickly to try to get kids off of phenobarbital in the hope that I can keep the seizures under control, but not have the medicine be even worse than the seizures in terms of learning. And I think some of the newer medicines are able to achieve that better, but every kid's different. I've had some kids who seem to feel sluggish or not themselves on medicines where that's not a common side effect, but that's a side effect for them. So that's the tough part, is finding for your child where is going to be the right balance to help them do their best in terms of getting the seizures hopefully to 0, but if not to 0, as down as much as possible without snowing them with a whole bunch of medications.
Okay, thanks.
I've had,
thanks.
Yeah, you're welcome. I've had pretty good luck in kids under a year with some of the medicines that are not yet FDA approved for little babies, but that we now have enough experience with that I think it's reasonable to try. So I think lots of people use levetiracetam or Keppra for infants, and it can make them cranky, but it usually doesn't make them too sleepy. For certain kinds of epilepsy, drugs like lacosamide or Vimpat or trileptal or oxcarbazepine, those are things that I've used quite a bit in infants and have had better luck in terms of sedation than something like phenobarbital. So I do think that we have more options, and more options than we did a few years ago.
My son's currently on Topamax.
Yeah, I have mixed feelings about it, because it does work better for kids who haven't gotten things under control with some of the other medicines, but it can absolutely slow down thinking. And in particular, we have to watch carefully verbal development, because we know that that's something that can be impacted by Topamax. So if he stays on it in the long run, the kind of thing I would do for a patient, even a little baby, is make sure that they get developmental evaluations regularly and early. For most kids, they don't even get an assessment for speech delay until they're 3 or older. But for a kid who's at risk, then I ask my developmental pediatrician colleagues to start doing testing as early as a year to make sure that their communication skills are on par, and see if there's any extra support we should be giving them.
Thank you.
I think with that, you're welcome.